welcome back. Hope everybody had a nice break. And we're moving on. So that patient came in and you know he has chest pain, or he's currently having an MI, or he had an MI. There's some reason why we feel the patient needs a cardiac cath. Certainly cardiac catheterization of the right or left, they call it, he's having a right heart cath or a left heart cath, is cannulation of the femoral, brachial, or radial vessels. And you do an arteriogram where you're visualizing the blood vessels, looking at the lesions and the percent of blockage. Right heart cath literally is your pulmonary artery catheter in the femoral or the brachial veins. You go up the vessel into the right atrium, into the right ventricle, and into the pulmonary artery. Shoots a dye, takes some pictures. In motion video of the heart beating as the dye goes through. Left heart cath is the concept of visualizing the coronary arteries to see what extent of infarction there might be, to view the bypass grafts to see how they're doing, if somebody already had been grafted, to evaluate angina-related spasms, and certainly to sometimes perform interventional caths like a percutaneous coronary angioplasty, which is the balloon going in, and we'll show you pictures in a minute, or placing a stent, which I'll show you that too. Dye is generally injected into the vessels, and you're taking a picture, recording that as you go. There's a video, I think it's a pretty good video, I put on your site to watch just to see a heart cath, give you a better visual. Okay, so cardiac catheterization certainly is a definitive diagnosis of heart disease. So traditionally, a patient came in, you didn't know what was going on, we got a 12 lead. Okay, so that's a big hint. We can interpret 12 leads. Sometimes that's all you really need. You got the diagnosis. But it's not perfect. Well, nothing's perfect for that matter. Echocardiogram has replaced a lot of heart catheterization now. Back in the late 80s, before then, no child went to heart surgery without a cath because you couldn't truly trust what you were seeing on the echo. But it was about that time period that the echocardiographer technicians, the doctors themselves, and the ability to visualize has gotten so much better that it's very common for children to go to heart surgery and skip the stage of a heart cath first, trusting it enough that we have enough information to do so. Certainly, the adult population, there's different reasons. Diagnostic, I want to see what's going on. I want to know where the vessel disease is. Where's the plaque? How much plaque? What's the percent of clogging? Okay. Measuring valve function. I can see pressure gradients. I can float the catheter through the right atrium to the right ventricle, and I can measure the pressure in those different chambers. There should be a certain gradient, meaning a difference. So let's say somebody has a vessel disease, okay, and this vessel's clogged. Then I'm measuring the pressure before it and the pressure after it, and then I'm comparing the gradient. So in a normal vessel, there should be no gradient, right? It should just be normal. But if there's a 70% difference in the pressure, then I have a 70% blockage. Where's the gradient? I'm looking at atherosclerosis, biopsies. I'm actually going in and taking a little piece of tissue, and then it's literally little claws. It goes, at one time, we had a kid in the cath lab, I'm like, oh, because it didn't just take a pinch, it took a strip tore off. You know how when you pull a little piece of your skin, sometimes you get too much? And we were like, oh, too much. Too much came out. Anyway, biopsies, going in and taking a little piece. Anatomy and pressure gradients, we said that. And especially in children, where is everything? Who's going where and what direction? What vessels are in what location? Evaluating grafts. We've done heart surgery before. We want to see if the perfusion's decent for the graft. And certainly procedures and interventions. And a lot of those are pediatric. And I'll show this toward the end. But certainly even for adults, we're going in and we're ballooning a vessel, which would be the most common things. We're putting a stent in place. Balloon angioplasties, ablations, is literally like, let's say I have severe pulmonary stenosis at the valve. Well, you don't have to have a pulmonary artery valve. They may just go balloon that and crack it open and open it better. Coiling, if somebody has very bad sinuses disease, they may go in and take a little catheter in and literally put little coils in the tube, okay, and then push them out with a wire behind it, and the wire has torque to it, So when it goes in the vessel, it just coils up, and it literally will clot off that vessel. So there's different little procedures like that that can be done in the cath lab. Okay, so how do we prep the patient for the procedure? Certainly it's informed consent. You want to make sure they know what they're doing and they're signing consent before they go. Education-wise, I did all the pre-op teaching for the cardiac kids when I was a CNS in San Diego and Cedars-Sinai. So literally the families would come in and make an appointment with me. We'd tour the cath lab and I'd go over what they should expect and how to handle it and what the typical routine is. So it's a little less intimidating if you kind of know what you're getting into. Pre-op labs, certainly EKG, echo, baseline enzymes, what's their clotting studies, do we have a baseline x-ray so we know what we're going in with. Generally you're prepping some area, lots of times it's the groin, and then pre-medicating the patient before they go in, certainly positioning them comfortably, and everything's monitored. We've got an EKG, we've got a pulse ox, we're monitoring everything during the process. Recording and monitoring, we said that. EKG continuous during the procedure, and pulse ox, we said that. Signs of contrast sensitivity. People can have a reaction to the dye that you're shooting, so you want to find out, do they just break out a rash? Did they have something before? You want to monitor for that. Anticoagulation status, because we'll kind of anticoagulate them during the procedures a lot of the time, so we want to know if they're stable coming in the first place. And certainly hemodynamic during the procedure. What's their blood pressure? Did they void before they went in? What's their temperature? It's cold in there. Are we keeping them comfortable? What's their respiratory status? And during the procedure, you sedate, make people comfortable. So usually it's called conscious sedation. They're comfortable, they're drowsy, they're sleepy, but they're definitely breathing on their own. They're generally not under general anesthesia in a cath lab procedure. They're just groggy and comfortable. Okay? So, typical cath lab going in for a catheterization is literally just picture taking and learning more about what's going on. But sometimes it's literally interventional cardiology, which is going in for procedures. There's a variety of procedures we do. Electrophysiology studies is mapping the electrical grid, so to speak, on the heart, trying to finding where the source of irritation is coming from. Very common for supraventricular tachycardia patients that go into supraventricular tachycardia. It's very disruptive, it's dangerous. If you can find the place, usually it's near the node, where it's the driving force, they actually ablate that little area, kill it off, and then people potentially can be relieved of the problem altogether. So it'd be electrophysiology studies. Percutaneous transluminal coronary angioplasty, or PTCA, is going in and a ballooning the vessel diseased area, try to opening it up. And 9 times out of 10 nowadays, that would include an intracoronary stent. And then the stents themselves have a little drug-eluting coating on them that tries to keep clots forming on them as well. It's done to compress smash back vessel disease, crack the intimal lining, creating a bigger vessel. This is certainly a treatment of choice. It's way better than having to go to open heart surgery. If you have an uncompromised collateral flow, you've got a specific lesion and a lesion they can get to. Okay, you can't have bifurcated vessels. Certain problems won't work. And the drug-eluting stents literally slow-release drug to block cell proliferation on the stents, creating a clot itself, so to prevent fibrosis on the stent while it's healing. A little bit more pictures here for electrophysiology studies. Again, diagnosing defects. Very commonly done for recurrent SVT, supraventricular tachycardia. You do the electrophysiology study, and then you ablate the site of reentry. The idea is to get them to trigger to do it. You put little probes. You can see it's multiple probes. This is a long procedure. A regular heart cath, boom, 45 minutes, they're in and out. Interventional balloon angioplasty could be a couple hours. Electrophysiology, it could be a 4-hour tour. It can take a while. You map and conduct the pathways. You'll induce the dysrhythmia and see what meds work. What can I treat it with, or can I ablate that area, radio frequency ablation, to treat the area. So there are drugs they found that came on the market, didn't come on the market, they found in labs, right, or in research, that were counterproductive. They didn't stop arrhythmias, they caused them. Some of these things can be useful in the lab when you're trying to cause it. They never went on the market to actually help people, but they're helping diagnose things and causing problems, and then they can find the location. Sometimes just for determining pacemaker programming is a reason. Back to conscious sedation, they're not under anesthesia, they're very heavily sleepy, and so you have to carefully watch their breathing and their blood pressure status. And like I said, it can take literally 3 to 4 hours. Then the primary angioplasty is catheterization lab for emergent percutaneous intervention or stenting if the facility also has that available. PCI, the idea is you by 90 minutes of arrival to the ER. So the target goal, remember, the sooner you get them, the less ischemia, the less damage to the heart. So you want to save muscle. So this is a quick diagnosis. Let's figure out what we have, go in and see if there's something literally vessel-wise we can rescue. It's better outcomes they're finding than thrombolytics by itself, to go in and to balloon and stent. But you have to be the facility that has a cath lab and can do these kind of procedures. So if you have an MI, let's say you're in a city like this, don't drive to that little hospital that can't do it. Go to the one you know has a cath lab. So it stretches that vessel to try and modify the intimal lining and displace the plaque. Okay, so here's just some pictures of percutaneous transluminal coronary angioplasty. So literally your dilation of the stenotic coronary artery using the balloon tip catheter. So I've got a catheter with a balloon on it. I'm floating it into the vessel, okay? And literally you can see it's floating in. You want to compress the plaque to increase blood flow. So I know there's this plaque area. Go in there, balloon it. You can imagine the first guy that did this everybody thought he was out of his mind. It's just going to blow up. And we'd always have the open heart surgeon standing there pacing the hallway, assuming the chest was going to explode. And it's surprising how well people do, really. Some restenose afterwards. It's literally best for single vessel disease, something straightforward they can get to, not some contorted thing. Again, the OR suite is standby, surgeons on standby, you have to have somebody around in case this doesn't go well. The problem is restenosis. So now you'll see it's even more popular if you're going to balloon and stent at the same time. Better outcomes than just fibrolytic therapy alone. It's a regular cath. Typically you go through the groin and you follow it afterwards to make sure they don't reocclude. Here's another picture here of coronary angiogram before and after PTCA. You can see A is the thrombolytic occlusion of the right coronary artery, and you can see how it's tight and small at that location, and you can see kind of the plaquey area there. And then B, I'll move this over, I'm using my hand, which is silly. Okay, so here's your lesion. This is just like little trickles getting by, right? So then they go in there, they balloon it, and you can see the vessel is more evenly, if you go all the way down, look how the size is more evenly dispersed. Okay? Just give you an idea what your before and after might look like. Here's another picture of intercoronary stenting, angioplasty with the expandable metal mesh. So think of a piece of chicken wire, okay? And if you pull the chicken wire, roll it in a ball and pull it tight, it's just this long skinny thing. But then if you put a balloon in it, it would expand out with all those little holes, creating a bigger space, right? It can stretch out like some of those meshy shirts we might wear. So it's expandable metal mesh device placed in conjunction with angioplasty. So it's on, the balloon's on the inside, and it expands out. So it helps prevent the restenosis that's associated with it. So when we first started doing angioplasties, it was great, you relieved it right then, but a lot of them re-stenose. They still ended up needing open heart surgery later, or they might have another heart attack. And it certainly had to be on anticoagulant therapy, drug-eluting stents to keep a clot forming, because again, this is foreign. It's not your own tissue, right? Mother Nature's like, better cover that up and attack it. So they're trying to get it to slowly be part of the intimal lining. And, but at first it's not. It's sitting out there. So Mother Nature's going to try and put little clots on it. What else is important? I think that's it. And then other interventional techniques, there's atherectomy devices, literally excimer laser angioplasty. We may see this more in the future as it gets better. To me, this seems simpler than having something foreign left in there. It's thought to be better for distal disease or with odd or tortuous vessels that you can't put a nice balloon or stent in. It's literally using ultraviolet energy with wavelengths and vaporizing, just zapping the plaque. So generally it's used when PCTA is not able to hit something like a long lesion or a clogged bypass graft. Smaller vessels and things that might lead to restenosis. Rotational atherectomy is along the same lines. Like PTCA, you compress and yet you're shaving off the plaque. So these are other things you might see at your institution. Okay, so what happens to these people? So we prepped them ahead of time. We knew their history. We checked them over. They were stable. We had lab values. We had information before they went in. Then we did the procedure, monitored them closely during the procedure. But afterwards, it's amazing how well people do, considering they have this giant tube in a very large vessel. But post-op, we monitor for signs and symptoms of an MI. They could have problems because we took them to the cath lab. What are their vital signs? Q15 vitals for a while, and then you slowly go Q30 for a while, then Q1, then they would eventually go home. Sometimes it's an in and out procedure that day. If they weren't coming, it was a scheduled thing. Certainly monitor with pulse ox. You're on bed rest for a while with the head of the bed no higher than 30 degrees because usually it's the groin. You don't want that to rebleed. Those were huge tubes in there. You had to hold pressure for a long time. You'll have, depending on where you work, they do different things. There's these pressure devices. You hold pressure for 30 minutes. Sometimes the goo, sandbags, depending on where you work, they'll have different protocols to keep that from rebleeding. But across the board, it's flat. Usually it's a 6-hour tour. They don't want them up. They want to lay flat to give that clot a good chance to be a clot. And of course, you held the site literally 30, 40 minutes sometimes to minimize the bleeding at the groin site where you remove the lines. Certainly you're monitoring the pulses and the insertion sites. You're constantly checking the insertion site. I don't like leaving it hiding under the covers. I generally pull the covers at an angle so I can kind of see it because if you do enough of these, somebody's going to bleed, and just a giant puddle of bed takes about 1 minute. So it's nice to be able to see it immediately. And certainly if there's always bruising and some nastiness, so you want to monitor that site. And you get huge flank, purple, ugly, nasty bruising if it bleeds inside. Certainly pulses, the foot that was involved, does it stay warm, does it peak, can I palpate the pulses? Antiplatelet drugs after procedure, usually after the intervention such as PCA. Hydrate, because they had a bunch of dye. Oh, back to the sheaths, remove the sheaths, I should have pointed this out. You do not usually remove arterial sheath and then a venous sheath. It looks simpler. Oh, they're both there, I'll just pull them out and hold pressure. Think about this. I could create a fistula. And then the pressure drops on that leg. So you generally pull one, that clot's stable, then you pull the other one. That's the typical way this is done. I don't think that'd be on state boards. That's too complicated. But you know that. When you're pulling these kind of lines, you don't, and you may have a patient in the ICU that has several sheaths in. You pull one, stabilize the clot, pull the other one. And I said that some of them have the clip medicated devices, the stitch device. There's different devices, depending on where you're at, they use to help stop the bleeding. The quick clot bandage, there's different things. We said hydrating because you just had a bunch of dye, and that dye is hard on their kidneys. I don't like it. I never liked it when I had a patient who had to emergency go to the cath lab. Okay, now they shot dye, and they emergency take them to surgery. Well, 9 times out of 10, their kidneys get in trouble. It's just too hard. You're already in a poor perfusion state, and now they've got the burden of trying to get rid of the dye. So you're much better off hydrating, get their body to flush it out. If you can, have the luxury of 2 weeks so they recover from the heart cath before they go to surgery. That's certainly a better scenario if you can do it. These patients may be discharged in 6 to 8 hours, depending on the diagnosis and what they had done in the cath lab. They may go to the ICU if it was like a stenting procedure, but if it's a routine cath, it may be an outpatient procedure, and they can go home. More post-op care. Certainly loss of distal pulses is a complication. You put a big line in that femoral, and everything below is a worrisome site. Certainly that kind of arrhythmias, tachyarrhythmias, or any kind of arrhythmia afterwards. We worry about retroperitoneal bleed. In other words, I put pressure on the groin, it's not bleeding on the surface, but it's bleeding retroperitoneal, so you get this giant flank, purple, ugly bruise. This is not attractive. It takes weeks and weeks to reabsorb. Certainly bleeding and bruising just at the site would not be uncommon. Then they could be dizzy, hypotensive, they had a big procedure, they had a lot of narcotics, now suddenly you're going to get them up 6 hours later. We talked about the kidneys already. There's a risk for spasm. We just put tubes in those vessels. It's shocking the heart puts up with it at all. So you can cause problems just by putting tubes up in those vessels. Certainly there's a risk for a neurological event. You're reasonably high risk for an air embolus because you've got lines, you're perfusing things. You may be on the left side of the heart where it goes straight to the brain. You can have a reaction to dye immediately in the cath lab, a reaction to dye later. They'll break out in a rash or something along that line. So you need to document that carefully because it's dangerous if they go to the cath lab again. And certainly the risk in the procedure of a coronary artery dissection, which is why the OR team tends to stay available. Okay, so this was an overview of the typical stuff that you look for and the routine procedures for a heart cath. Now I just want to give you a little bit of information for a pediatric interventional cath because it's the same thing. It's the same cath lab. It's the same setup, same pre-op teaching, same follow-up in the post-cath, but typically what they're doing in there may be different, and certainly what they're looking for is different. Sometimes it's a balloon valvuloplasty. They're rupturing the pulmonary artery because it's a pulmonary valve because it's very tight. Maybe they have pulmonary stenosis, so they're flowing up there, ballooning that. You may have coarctation of the aorta, a scarring on the aorta, usually right at the arch area where the ductus would have been, and they may go up there and try and balloon that and open that up. So you literally will go in. Sometimes, come down. Okay, so embolization of a pulmonary artery or PDA. So if I was born and my patent ductus didn't close, you can go in the cath lab and put a little vessel in there, coil it, like we talked about. Coil collateral vessels, not an uncommon procedure. You have a kid, they're young, you're prepping them for surgery. You want to do their final repair to create pulmonary artery because they don't have one. Okay, but what they've just done is put all these collateral vessels. So it's a very cyanotic child. They have tons of collateral vessels. So if I go in and I fix it and we put in a graft, so now there's a pulmonary artery, they're going to get too much flow, right? It'll be excessive flow because of all those collaterals. So what we'll do is bring the child in and do the right lung first and may spend hours in the cath lab coiling all those collaterals on one lung. Then the next time the kids get more cyanotic, next go to the other lung next month, coil, now he's really cyanotic, and then you take him to surgery to repair. So you've got a more balanced flow. You're trying to balance the flow to the lungs. Blade septostomy is common in the newborn. Let's say I have a child born with transposition of the great vessels. So the pulmonary artery is on the aorta and the aorta is on the pulmonary artery. They're the opposite where they should be. You can't live like that because you've got one systemic circulation and one just going back and forth to the lungs. They're not communicating. So in order for that baby to survive, you'll put them in the cath lab, and you've got your foraminal valley, right? It's not quite closed yet. You were born, okay? So you'll go in, you'll take a little blade, and you'll go through there with the catheter, and you open it up, and you rip it through. I mean, literally, the little heart jumps down like several inches, like, whoa! And you're ripping through there to open it up, and you see the kid just get pink. So you're creating a shunt, basically, so the kid can survive. Sometimes those are done emergency at the bedside. One of the cardiologists, Pete, the guy I worked with, he said he carried a blade in his trunk because he'd get called emergency to some of these small towns and literally do it with an echo at the bedside. And we talked about EPS surgeries. Children have electrophysiology surgeries just like adults to treat underlying arrhythmias for ablation for supraventricular tachycardia. Okay, so If you have any questions about these 2 lectures, pre-spelling it to class, we can review. I would highly recommend taking these notes. Now you've heard the lecture. Now take the notes, read the chapter, kind of add to it. It's a second voice telling you the story again, and that usually adds to the clarity for you quite a bit. And I hope you're enjoying these 2 lectures and it helps you in the class. I'm going to escape out of here and escape out of here. Oh, sorry, memorizing. Yeah. Hang on, guys. That's it. Have a good day.